home regs, which will require that persons work at their principal place of employment, and they will not be permitted to be engaged in other types of part-time hustles, so to speak, at other rest homes, so that we can minimize the potential spread from rest home to rest home. So those regulations will be approved and gazetted very soon.
I know that we have limited resources in terms of caring for our seniors in Bermuda, but I'll still need to ask the question because rest homes everywhere that we've seen this have dominated the news. People want to know, can you walk us through why we have not been able to earlier on just say that they're just confined to one place in terms of the resources that we have realistically on the island?
I'm not 100%. I follow the question. I'm sorry, Jonathan.
We've been hearing for maybe 6 weeks now of some scary stories in rest homes around the world. People will doubtless ask why we haven't restricted the movement of staff between homes earlier.
Well, the Residential Care Home Regulation Officer has been meeting regularly with the rest homes, and in fact, in March, the recommendation was for them to cease the process, the process of allowing persons to work at multiple places, and it was hoped that that would have been done on a voluntary basis. We see that that has not necessarily been the case, hence the movement to regularize it through the regulations.
Thanks, Minister. In terms of healthcare workers, are we at a point with testing where we're able to really focus on testing our healthcare workers as an at-risk population? They're dealing with sick people?
As you'd be aware, there is a global shortage of testing supplies, and so that is the struggle that we have here in Bermuda as well. Ideally, individuals who are working in a high-risk profession should be tested preferentially because they are with a vulnerable population, that is individuals who are not well. And so if there were an abundance of supplies, an unlimited amount of supplies, indeed, there would be very broad testing, and we look to the day when that will occur, hopefully sooner rather than later. In the present scheme of things, excuse me, hospital employees who are symptomatic obviously are tested quickly and isolated as well. Hospitalized patients are prioritized for testing. Individuals who are identified by their family physician as being at risk are tested according to a system of prioritization. And so there is at this time a need to balance the surveillance, looking for COVID-19 infections in the community, with the supply of testing equipment that's currently available. And because there is currently a limit to that, we have to be very judicious in who's tested.
Thanks for that. On a similar note, I know everyone is looking for ventilators at the moment, they're gold dust. Are you able to tell us where we're at for our ventilators and the projected need, depending on these models that we're looking at, that we may need of them?
That is a hospital question. I do know that they have been very, very meticulous at estimating the need, anticipating the need, and acquiring additional equipment, but I would prefer that you put that to them to give you precise numbers.
I had one final question. I don't know if anyone here will be able to answer it. We have had issues with separated parents, divorced people, in terms of visitation, where our shelter-in-place regulations have affected that in terms of being able to spend time with their children. Is there anything that can be done with the amending, I believe it's 3.3 of the shelter-in-place regulations, to make an exception for the handovers of children?
So we were very clear, Jonathan, when the legislation came in place, that it is up to the parties to work out a solution. So if they are meeting at a grocery store on a specific day and they're able to work it out, well, we want the parties to work it out amicably. In the circumstances where there is not a defined decision, Section 3.3 predicated that where we were at the start of the shelter in place, the child must stay there to the end of the shelter in place.
Thank you kindly.
Good evening. Following up on the testing kits and it's the swabs that we're short of. Approximately, how many swabs do we have to complete the tests, and how many are we missing? And is it just swabs or?
That's a laboratory inventory question, and it changes every day. I can say that the laboratory supervisor gives an update regularly. Over the weekend, I believe the number, we acquired some additional items so that the testing capacity went up from a very low number to something like 140. Laboratory inventory for COVID testing is quite complex. There are several ingredients that need to be in place. As we've talked before, it is a matter of several key items, any one of which can be the rate limiting step or can limit your testing capacity. My understanding is that as of today, it's more than 100, but there are items anticipated this week, which will raise that considerably. We hesitate to mention it because we have had some disappointments in this setting of embargoes and changing laws with regard to what can be transferred from one country to the other. But at the moment, we are able to test those who meet the criteria for needing testing at this time. And we continue to follow the World Health Organization's advice on testing, which, as you know, has expanded and allows people to be tested in the community who do not necessarily have a travel history risk, so that we're meeting the current need as we see it. But we look forward to having much more testing capacity available so that we can test without any particular criteria that limits us, and so that people, particularly those who need to be going back to work or need to change their lifestyle so that they can rejoin their families, that kind of thing can be done.
We know the United States has been one of those countries that have put restrictions on sending out supplies. India is another. Are there any other places that are causing us problems in getting these supplies?
I can answer that, Dr. People. You're right, John. Unfortunately, the United States has, as the Premier indicated, I think at Thursday's press conference, a particular executive order, so to speak, from the President. However, likewise in China, the Chinese government have effectively, in order to try to curtail what other countries are seeing, is counterfeit, PPEs, masks, testing kits, and the like. They have actually said that from anything that's going to be exported from China, the Chinese government said that it must now go through a set of quality control. So, for example, some of the equipment that we've been trying to source from China for, we might be very well on week 6 now. The Chinese government, as recently as last week, indicated no more PPEs can be, first it was N95s. They said you cannot export N95s without us first going through quality control. They've amended that regulation and now enlarged it to say that we now will not allow for PPEs to be, except for face shields. So face shields can go, but everything else that's a PPE has to go through quality control. It is a moving, as Dr. People said, it's a moving target. So the regulations with respect to the country, China in particular, seem to change daily. So as of today, as of last week, Wednesday, that was the position. If that's the position tomorrow, I don't know. We did have a conference call a couple hours ago with our agents in China, and they've indicated they're watching the space because there's word to suggest that there's going to be an easing up of that particular quality control measure because of the drastic need worldwide for these supplies.
Okay, thank you. Mr. Premier, compared to other countries, Bermuda has a high mortality rate and a low testing rate. Well, not really low. We're in the top 25%, but as far in testing.
Yes, so I just want you to repeat that.
Yeah.
I don't want to say low testing rate.
No, 25%. I correct myself. But we're 15th overall in the world as far as mortality rate. Please comment.
I'm not entirely certain what you want me to answer.
Well, as of how concerned should Bermudians be that we're 15th in the world in mortality rate, and most of those countries that we're up there with, 10 out of the 15, are bigger countries, and there's 5 smaller ones like ourselves, like Andorra, and I think, I'm trying to think of the other, San Marino is another one.
I mean, there's different circumstances that happen, and as I started this by stating that we report these things as, numbers, and it's not as though if we know about the individual circumstance in which people are facing. But one of the things I think of which we've said before is that this disease affects those persons who have pre-existing medical conditions. And so when you have an incidence, as we do in Bermuda, a high incidence of non-communicable diseases, this could make our population more prone to that. Would I had wished that we avoided deaths inside of this country? Absolutely. Is that a realistic assumption or thought to have? Probably not. But the fact is that our jobs right now are to make sure that we do what is necessary to minimize that number. You would have heard me say last week that the modeling information which has been provided by the epidemiology and surveillance unit has indicated that our worst case scenario is in excess of 700 deaths. We will be releasing that information publicly following the cabinet having its review of it, and that may come later this week. But I think that it's important to recognize that as we are dealing with this virus, there will be persons who succumb to it as they have around the world. Our job is to make sure that we are taking the correct strategies in order to minimize that. So whether it is at the Bermuda hospital, where I've managed to see where they have converted old wards to be ready for any particular surge, whether it was the response that Dr. Peake Ball had given towards the fact that they have acquired experimental treatments that can be used in compassionate care towards the end of life to see if that may help, which they're being able to do overseas, and additional treatments such as talking about plasma, et cetera. So there are lots of things that our hospital are doing. Our medical community, I want to pay tribute to them, the officers in the Ministry of Health, who under incredibly difficult circumstances this weekend managed to come up with a workaround for testing to enable us to test all those persons at the resting home today. And I can't get into the challenges of which individuals are working under, but let me just give you a story and an example. Last week there was relief that we had received a supply of swabs and viral transport media. But in all instances, the department, the Ministry of Health, makes sure that these things are validated prior to use. The initial validation worked. The secondary validation did not work. So we went from a perspective where we thought that because we know that we have the testing kits in order to do the tests, but the question is, the swabs and the other things to put them in. So we ended up with a shortage. And so we're at this place where there are dictates from the political leadership that we have to make sure these persons in the rest home are tested, versus the realities on the ground where, well, we don't actually have the viral transport media to transport those supplies. So what did our public officers do? Over a weekend where persons were with their families on the holiest weekend of the Christian calendar, worked, put together a workaround which was endorsed by the World Health Organization, and managed to mock up and put these things in place so that we were able to do that testing this weekend. And our health officers are improvising on the front line on any given day. And it is tribute to them, it is tribute to the team led by the Minister of Health, the Chief Medical Officer, and Nurse Jennifer Wilson, the head of the Epidemiology and Surveillance Unit, who are doing an amazing job to make sure that we can keep up. So in answer to your question, we have to do what it is that we can do. Would I like to say that we had no deaths? Absolutely. Does it pain me to say that we had deaths? Yes. It pains me even more because I happen to know some of the families who are dealing with that loss. And that is the reason why it is incredibly important for everyone to pay attention to what it is that the government is putting out to protect lives, and to make sure that you recognize that in doing that, you are supporting healthcare workers who are doing their all to make sure that we can battle this.
I'm sorry if I didn't hear you exactly correctly, but of the swabs that we got last week, after they were tested, some of them were deemed not to be good enough, or
yes.
Okay. All right. Do we know how many that was?
No.
Okay. Just to follow up on a question from Thursday, I'm not sure if I asked it exactly the way that you understood it, But compared to since the pandemic began, you've been, sorry, I'm just completely messed up on my list here. In some countries overseas, between 10 and 14% of those supposedly recovered patients are getting sick again. With the Ministry of Health, will the Ministry of Health consider extending the mandatory isolation period for those people for a longer duration? In like South Korea, they've had what they're calling reactivation, where patients who have been cleared have been getting sick again, and they feel like the coronavirus is hiding inside, not dormant, but latent, I think is the word that they used. So will we consider maybe that a longer period is necessary, or going back and rechecking with these people just to make sure that they're not reactivated?
I'm so happy to be joined by the Chief Medical Officer. Chief?
Thank you. I was actually hoping to be able to have that question, because it's an opportunity to talk about a couple of things. One is that it's very difficult sometimes to understand the statistical information that comes out of different countries. The example that you gave, for instance, of the reactivation potentially may be indeed a reactivation of disease, but it might also be that an individual was tested and was told that they had COVID-19 at a time when they were, it was too early to really prove that they had COVID-19, and it was a false positive, and then they eventually did get infected. There are situations where individuals may have had a very mild or subclinical case, and thereafter their immunity is not adequate, and they are then capable of getting infected. The point is that the evidence is really evolving. The information, the studies have not been done to really follow the natural history of the disease, and testing capacity is variable. It is somewhat unpredictable. There are countries using tests that, for instance, we would not care to use in Bermuda, or that have not been validated. And so the results are sometimes not what we expect, and it can be therefore difficult to compare country to country in terms of the natural history of the disease and what we're seeing epidemiologically. Likewise, even figuring out the mortality, what the mortality rate is, depends. That is a proportion, so that you're having to know the number of individuals who actually had the disease versus the number of individuals who die from the disease. So a ratio, I should say. So the problem there is, if you're not doing a lot of testing, the denominator is smaller than it would ordinarily be if you were doing a lot of testing. And so that you can sometimes, through statistical artifact, look as though you have a very high mortality rate, when the problem is that perhaps you need to be doing more testing, and then you would find individuals who are asymptomatic or who have mild disease who actually live. So you would actually end up having a lower mortality rate. So the figure you mentioned about Bermuda being the number 15th, internationally, I think merits some further investigation, and it'll also be interesting to see how over time, when there is more access to testing and we can identify people who don't necessarily end up in the hospital or critically ill or who die, and get a real sense for what our level of care and our ability to address the diseases in the country. So I think that the point I'm trying to make is that it is very difficult at this point to make valid comparisons country to country, and the information has to be taken with a grain of salt.
Okay. Well, they were doing it on a per capita basis?
Yes, that too. You can certainly, as you know, get statistical artifact from very, very small populations when you're dealing with very, very small numbers. Right. Someone gave the analogy to me that Bermuda has had a small number of individuals perhaps in the Olympics, and the number of medals in the Olympics compares quite favorably to that number of participants in the Olympics. So you really have to be very careful of the comparisons across jurisdictions because of the difference in population.
Just to get back to in the Bermuda situation, so once people are deemed recovered, to make sure that we don't have a false positive or latent or dormant or whatever term you want to use. What sort of checkup goes in after they've been deemed recovered?
In a resource limited environment, retesting is not practical. We have to limit the testing at this moment for those who are high priority. As I said, hospitalized, healthcare workers, those individuals looking after vulnerable individuals. But in days ahead, when we hope to have adequate testing, the gold standard obviously would be to assure that an individual has converted to being negative after they have been positive, so that they can be assured that they are no longer infectious to others. And in some limited areas where there is adequate testing supply, that is done a week or two after recovery. But we're not at the point of being able to do that at this time here in Bermuda.
All right, thank you.
Premier, I have another further question. By any chance, is the finance minister going to be presented? Because I've sent him a few queries, and this one particular lady is asking, she's a small business owner, a beauty shop of 9 staff, and she's paid out $7,500 this month to keep her staff insured. She's got no income coming in, and she's got maybe, what's this? May is soon coming, and she's going to have to go in pocket to keep her staff. Her concern is that she wants to keep up her staff insured, but with no business coming in. What type of relief will she get?
The Minister of Finance will be joining me, I think, at this podium on Wednesday. But what I would say for that particular business owner, number one, I would thank her for doing her best to try to make sure that she can continue the health insurance of her staff. I think that's something that is very important, something that I commend business owners who are reaching into their pocket and sharing that particular sacrifice. So I thank her for that. If she has a specific query of which she wishes to have addressed, surely the best way to do is to contact the Ministry of Finance or the Minister of Finance directly. If she wants to send me an email at premier@govt.bm, she's welcome to do so as well, and that can be forwarded to the Minister of Finance on those specific things. But I know the Minister of Finance has been working hard in conjunction with the Minister of Labor, Community Affairs and Sport to provide relief to employees who have been made unemployed due to the controls that are necessary to keep the spread of this pandemic to a minimum. But what we also need to do is to pay attention to not only our current plight of our businesses that are on island, but also the future plight of those businesses. And I do believe that the Minister of Finance will be joining me at this podium on Wednesday.
Any other questions?
With that, another question.
Yeah, just one last one. I'm sorry, Dr. Peakball. So after a person, since we're not doing the testing, do they?
I'm sorry, start the question again. I couldn't hear you.
Sorry. After a person is either discharged or said that they're recovered, so because we don't have enough testing, is there some sort of follow-up where we ask them to check on their symptoms like 4 days later or a week later or something like that?
The current advice is that individuals who are positive are isolated for 14 days after the positive result, or 3 days after all symptoms have resolved, whichever is longer. So that is the protocol that's followed. So you're asking if there's
afterwards,
other,
just to make sure that they're not
any follow-up thereafter. That has not been put in place yet.
Okay, thank you.
Thank you very much. I thank the members of their media for their attention. I thank the ministers for joining me here today. I thank the Chief Medical Officer of the Nurse Epidemiologist and the Commissioner of Police as well. And I'd like to remind all persons that we are dealing with a situation and with a virus that does not discriminate. And I want us all to remember that we all have a responsibility in order to keep our country safe. I want to thank everyone for their continued support. I want to thank everyone for their continued prayers. And I want to ask everyone in Bermuda to keep in mind the families who are grieving this evening as they deal with the loss of loved ones due to this virus. Have a good evening.